invite Dr. Nitin and Dr. Iyengar if he's here to come down. Subran sir, Nitin sir and Subho, could you please come and chair this session?
The makeshift speaker and makeshift chairpersons.
Without any further delay, I tell Dr. Subho Banerjee to start the lecture.
Thank you, sir, and thank you organizers for having me here, Dr. Abhijit and Dr. Akash. So I've been given the task of presenting a lupus nephritis case, and the deal was like we wanted to look at what were the more emerging therapies and everything. So rather than putting a very interesting case, what I've brought to you is a very morose presentation. So what others have presented is like very heroic things and glamorous things also, but what I'll be presenting is more routine. But I'm very sure you'll all recognize from the pattern that I'll be presenting, and you must have seen some of these in your own practice. So just to start with, so this is a 17-year-old girl with no previous comorbidities, a student from a relatively upper middle class kind of family, and in 2019 she went to IGA Chandigarh because she was based in Chandigarh at that time, and she had fever, facial rash, typical butterfly pattern, and in December 2019 she also developed some arthralgia and significant alopecia. I mean, how much significant for a young female, I don't know. No oral ulcers, borderline anemia and borderline low platelets. With that, she was referred to a nephrologist because there was some edema also. And then she was seen in PGI Chandigarh February 2020. And in the meantime, while she was being evaluated, COVID struck, and it was a little delayed. And then in July, so it was almost, I think PGI Chandigarh did actually close down their routine OPDs and everything. So the treatment was delayed until July 2020. And then at that time, she presented with a right low ozone pneumonia, and then she was treated and everything. So, what happened is like the hemoglobin at presentation was around 8.6, a low total leukocyte count of around 3600. Platelets were normalish 1.8, urine albumin 3+, and there was some blood in it. Serum albumin of 1.8, C3 low, C4 low, creatinine normal, and 14 grams of proteinuria. So, if you look at the biopsy right here, if you look at the biopsy, I mean, the tissue was inadequate. There were like 3 glomeruli in the LM, and there was, nothing in the immunofluorescence tissue. So, but what they did is they tried to look at the details and whatever. So, based on this, there was only some mild to moderate mesangial hypercellularity. Just somebody has actually underlined the report for us. And mild podocyte hypertrophy, they must have scratched their heads about that, and there was nothing. So this primarily this looks like a class 2 with a heavy proteinuria, right? There is almost nothing, but probably there is some indication that if you find deposits in the capillary wall and everything, so ideally class 2 should be only mesangial. So probably that is the reason why they thought of treating this lady somewhere like class 3. So they gave IV methylprednisolone pulses, mycophenolate. They started at 500 BD and then upgraded to PDS. And this is what happened next. So from 14,000, she came down to 1500 milligrams of protein in just 3 to 4 months. And by this time, so the MMF dose was increased to 2 grams per day, and the Viceron was slowly tapered, although quite slowly in fact. Then there was a jump in the proteinuria. So from 1500, she went up to 2100, and the MMF was still jacked up to say 2.5 milligram per day, and the Viceron was still tapered to 5 milligram per day. With this, the proteinuria did come down to 1.1 grams. But then again, and they actually did a MMF area under curve, which was 49 and quite acceptable. But so, but at the end of the day, in March, so this is around 7 to 8 months of therapy, the proteinuria was still hovering around 2 grams. So graphically, this is what was happening. So if you could see here, the proteinuria is still around that 2000 mark, and the albumin, although it went up a bit high and then it's again back. So they thought of repeating a biopsy because the initial biopsy was not so good, not so informative, and there was only partial remission. So they repeated the biopsy. And so this is the biopsy. And if you look at the details, so 13 glomeruli, two globally sclerosed this time, which is a little high, little too high, I guess. And there was 2 fibrous crescents. There were some fibrous crescents also. And so thickening of basement membrane. So this is like class 5 now. And more of, a lot of activity in the IF. So this was class 5 plus 3, and there was a lot of chronicity. You see, it's been graded as 4 by 12. So with this chronicity and transformation, the questions were like, what was next? Now she could have been thought of as a MMF failed girl. So the options remained between cyclophosphamide and probably a multi-target therapy. So since I guess this was a young girl, so they probably opted for multi-target therapy because she's a young female with reproductive potential. And there is some evidence to say that maybe class 3, class 5 plus 3, class 5 plus 4, they do relatively better when there is a tacrolimus base. But the concern must have been that with a chronicity index of around 4, like is there a real risk? So they did go for multi-target therapy, and they went as per the textbook, say tacrolimus 4 mg per day and MMF 3. So this is what happened next. So proteinuria was at that time was around 3.3 grams. The serum albumin was 3.8. So they started, and so MMF was somehow brought down to 1.5 and 1, and then MMF was continued. So there was a brilliant response. You see here, so 378, 269. So it was quite good. It was quite good. The albumin built up here. The C3, C4 almost became normal. So they were able to taper down the tacrolimus dosing, and the levels were also quite well maintained. So they were able to bring it down to 240 milligram only, and by this time tacrolimus was tapered off. So she was only on MMF. This is all in PGI Chandigarh. So then the moment they tapered off tacrolimus, the proteinuria jumped. C3, C4 fell. So in response, what was done is MMF was again built up from BD to TDS. There was some response initially, but again this was not very comfortable, and it came back around to that 1800 mark again. C3, C4 was again quite low. DSN was a little highish. So it is at this time. So this is the graphical representation that although there was a distinct drop in the proteinuria, but again it just built up with the withdrawal of tacrolimus. They also tried to add tacrolimus here, but it probably did not work very well. So this is the time when she got into an MBA course, and she came over to Ahmedabad and came to us. Now, when she came to us, she again had some maculopapular skin rash over her upper limbs and the lower limbs, hair loss. Anemia had developed from 8.2 to 7.8, albumin of 3.4, C3, C4 low, DSNA highish, and a 24-hour unit protein of 2.8 grams. So we did continue the tacrolimus because she was not available for the recurrent consultation because of her coursework and everything. And we did think of repeating the biopsy in view of the previous chronicity. We are a little worried about that, like what has happened to the chronicity because of this tacrolimus exposure. That is more than a year almost. So this is the biopsy at our end. This is the third biopsy that she has undergone. So 25 glomeruli, again thickened membranes, and some endocapillary hypercellularity still. And IgG, IgA, IgM, C3, everything is positive. So full house kind of thing. So class 5 plus 4 this time. And luckily no chronicity. So 0 by 12. So it does depend upon how you are seeing it, what sort of sample you have, everything. So what next was the question. Now she has failed MMF, she has failed multi-target therapy. So the realistic option was really cyclophosphamide, but at 18 years of age, cyclophosphamide was a really tough question. And the second question was, if we opt for cyclophosphamide, is it going to be urolupus or is it going to be an IGA protocol? Because she has already failed twice. What do we do? So we did think of urolupus because that is the current state of affairs. That there is hardly any point of going for an NIH. So, and our protocol is to give leuprolide injections monthly basis because there is some evidence to say that it protects the fertility. So this is what we did, urolupus. So 500 milligrams, 6 doses, 10, 14. Okay, this is it. So 10, 25, 11. It was delayed a bit. So we gave 6 doses, and this is what happened. Okay, so she had gone up to 4.5 grams of protein. From there, she came down to around. I mean, initially there was some dip, but it stayed like that. There was probably no improvement. We had to actually give albumin supplementation here because 1.8 is a little too risky, we were thinking, and the DSDNA actually went up. C3 was quite low, and she was having some anemia because the hemoglobin has gone up to, say, if I am not wrong, so 10.5, 11. It fell to 8.3. We don't know. We gave some. This was also the time when she was again developing some rash. We had to pulse her in between, and this was the time, this was end of the urolupus, and we started her on azathioprine. Now, one of the concern was, since she was resistant to MMF, so what should be the maintenance drug? I mean, there is hardly any evidence to say that, but somehow we decided to go for azathioprine 75 and then again jacked it up to 100 milligram. And by the end of this time, she was at 8 grams of proteinuria. So not responding very well initially, but yeah. So then again, from there, I don't know what was wrong with this, but now the proteinuria did come down to 1400 and then came to sub 1 gram, which was quite good. The DSDNA was still quite high. The C3 was actually quite low. Creatinine was sticking around. There was some improvement with the albumin. But then again, what happened is the proteinuria went up again. So graphically, this is what has happened. I'm not sure about these results, but otherwise it did come down a little, and again there was a uptrend. So the next question was, what next? We waited for a while, but there was no improvement. She was having a lot of edema and everything. So just as we have discussed, rituximab can be one of the rescue therapies. We didn't have much else to go on with, so we tried rituximab. So we dosed it at 375 milligrams per meter square, which came to around 525. So we gave her 500 milligrams, 4 doses. We initially planned 4 doses with CD19 monitoring if required, and then 3 doses came back to back. So 7, 14, and 21st of September. Then she had fever, neutropenia, and intercurrent, some viral infection kind of thing. And then there was some delay in the 4th dose. So by this time, if you look at this, so albumin, we did not get the 24 hours. So 4.5 grams came down to 2.9 grams. There was some issue with the PLC levels, so they went down. So azathioprine was stopped. And there is some evidence to say that rituximab combination with MMF is probably better than rituximab combination with azathioprine. And in all the surveys that have been done, so that's the most common combination that is being used. So we tried to put her on MMF, and again the total counts were kind of low, so we stopped MMF. So she did receive the rituximab doses, however. So by this time she's on with low dose steroids, rituximab 3 doses, and since we could not carry on with the dosing here, we actually gave, despite the CD19 count being very low, we did actually go ahead and give the 4th dose of rituximab again. Currently she is only on steroids, and this is what is happening to her. So rash. So this is I don't know how common do we see that. Textbook says that if you are able to control the renal disease, you should be able to get away. And with all this immunosuppression, extrarenal lupus should at least be at bay. But that doesn't happen. I don't know. In our experience in Gujarat, we have seen patients coming in remission with seizures, with severe anemia, with low platelets, rash and everything. So this is the kind of rash she was having, despite chronic lupus kind of things. So the entire treatment was being done by our team, rheumatologists, skin, dermat people. So this was actually a multi-disciplinary team that was doing. So if you look at the 2024 lupus guidelines. So what is required for a patient with unsatisfactory response is that you need to verify the adherence to the treatment. So most of it was given IV in our center, and whatever was done at PGI Chandigarh, they also did actually the MMF AUCs and everything. So we can kind of assume that he was doing nice with the adherence. So, and then proper dosing. So this was also done. Repeated biopsies were done to find out like if there is a misdiagnosis or everything. So we have kind of checked all the boxes. So the problem was what next? So is that the end of the road for resistant lupus? We can call it resistant because she has failed multiple first line options and even the second line options. So is it the end of the road? So I was thinking that Fuller sir would have done something for us and he would have paved the road, but missing. Okay, so thank God I got these slides. I thought this would be an overlap, but luckily it's not. So until here, if you see, the number of agents is very limited. It's only about the dosing and how we go about it that has changed, with some exception that CNI is being used as some first line in at least some geographical areas. But recently there has been a plethora of agents which have come up with good hopes. Previous trials did not do well. So it is definitely no. So what we have here is a very nice cartoon which has shown a lot of new agents. The tulip, the anifrolumab. So this is the interferon 1 receptor antagonist. The obinutuzumab, that trial that has been that just what we will talk about. The belimumab. So this has got FDA approval. Also the voclosporin has got FDA approval. So there are some options. But the question was the availability. I don't know whether there was a lot of discussion whether of giving obinutuzumab, but I don't think it's available out of clinical trials. Voclosporin is damn costly. So current considerations for in this case. So this is just 2 weeks back. So just want to wait whether rituximab effect will set in maybe in a few weeks or something. If we can manage it conservatively, we can find some resolution of the events and everything. And then the other options would be an anifrolumab trial, because we have an ongoing trial at the NHS Medical College, Ahmedabad. So then they are still recruiting. But in general, the response in lupus nephritis has not been very good. And there is a risk of zoster and other infections. So we don't know. Belimumab. So this can be used in combination with MMF, but with heavy proteinuria, the response is not very good in the lupus BLISS trial. And the cost and availability, the cost is too much, and probably it's not available out of trials. And obinutuzumab, I'm again not sure of the availability, but they have some very good results that are coming up with novelty and the results, trials which have just been published. Not published, but the results have been just declared. And voclosporin is like very costly and probably not available at all. So I think the options are quite limited, and I don't know how we'll go about it. So we are currently trying to think of anifrolumab because of the availability and the possibility of actually giving her that. So thank you for speaking. So any input from the house would be like very much welcome.
Can you update the lupus?
I think the first response should be to taper off MMF, because sometimes we have seen patients with transplant on MMF. We are trying to dilly-dally the situation, and they go down really bad to like sub 1000 counts, and it becomes really risky. And for this kind of patient who is already proteinuric, exposed to multiple immunosuppressives, so developing an infection can be fatal. So I think that can be one of the approaches to maybe bring down the dose a bit, but with 1600 and like sub 2000 kind of levels, it would be really difficult.
The two options are given that IV couple of customized or multi-target therapy. But this is not the first time. IV couple of customized or community. That would be the first choice.
No, so she actually was treated. So probably what might have played in the minds of the treating physicians was like the fertility issue.
Second is that she was pulled over many times.
No, she did. No, she did. She actually did. So they actually gave 2.5 grams.
So, see, this is the first time.
No, this is with tacro. This is with tacro. Just with it. So they actually give 2.5 grams. So 3 grams is the maximum dose. So she's not very largish. So probably she would have weighed around 52, 53 kg, not more than that. And they actually went up to 2.5. And they were actually doing it quite good because they did a area under curve to find out if they could go further up. I think they were kind of happy with the dosing that they gave. And this was kind of a little short if you just have to do some nitpicking, because from the dosing was started around this is around July, and then by the end of March they were actually stopping. Might have continued, but this is at least a partial remission. They might have waited a little bit. So they're I don't know.
This is what I would like to say is that whenever I see a patient who is responding well and then not responding, usually they're stopping the steroids, especially young ones. They stop the steroids, they continue them. So that is one of the issues.
But this patient actually, I don't think she would have done that. It's always possible, but yeah, she did. She does. Because when we started cyclophosphamide, zero lupus, we gave her full dose. We dose it like the medium kind of scheme that we do. Because there is some talk that most of the initial effect is because of the steroids. We just wanted to give her steroids so that we can be sure that she has been dosed properly.
I think very interesting place one of the most challenging places. I think these kind of cases counter in combination that probably the combination of addiction of these type of things. There is clear public strategy. Nothing less to offer. Unfortunately, I agree with life is more important than the I just feel like addiction and the combination.
There's probably some recent publications regarding rituximab with MMF. I'm not aware of that.
So I think you can have the further discussion. So I think we'll go ahead with the mixing. Sorry, I think we have to go to the next presentation. Thank you, Subho.
Thank you, Subho.